Good evening. This is Dr. Kumar Belani, and I'm speaking to you from Minnesota, where I work, professor of anesthesiology, medicine, and pediatrics. Uh, Sorry I couldn't be there. It's evening for you, but it's morning for us. Let me share my screen, and I think you see that screen. So let me upload it. Continue to share. Good. Okay, so hope you can all see the screen. I will be talking today on anaphylaxis, give you an update, and also discuss the role of biologics that are newer modes of therapy for our patients. This is the Children's Hospital, Masonic Children's Hospital, where I work. And as you can see, it's quite beautiful and it's very close to the Mississippi River, which is the state where the Mississippi River begins, if you remember your geography lessons in school. Now, what are my conflicts? Typically, none for this particular talk. As you can see, sorry, I went. As you can see, I'm involved in research with remimazolam, amisulpride in children, and have received grants from NIH, Pfizer, Medtronic, Acacia, and Eagle Pharmaceuticals. I'm a hotline consultant for the Malignant Hypothermia Association of the USA. And by doing this talk, I definitely get some personal academic advancement. So anaphylaxis, as you know, is a terrifying, life-threatening event, and it occurs suddenly. It's quite profound, and one experiences unexplained and unexpected hypotension. Under anesthesia, one will see bronchospasm and cardiovascular collapse. It's an immediate type hypersensitivity reaction and typically involves at least two body systems, the skin, the respiratory system, the GI system, the cardiovascular system, and sometimes the CNS when the patients are, not anesthetized, or they might even be under sedation with monitored anesthesia care, and you might see them getting suddenly sleepy or getting a seizure, things like that. Now, intraoperative anaphylaxis, like anything else, is typically rapid in onset. There's variable severity. So some might be mild reactions and some might be severe full-blown reactions. I'll give you some examples of some case reports. And response to the timely administration of epinephrine. And this requires quick recognition and keeping this at the back of your mind that this could be anaphylaxis. And so when done so, it rarely causes death. Now, the global incidence is anywhere from 50 to 112 episodes per 100,000 persons in 1 year, and the prevalence is 0.3 to 5.51%. And clinicians, we will definitely encounter a patient at least once or twice in our careers. The most common association of anaphylaxis is with food, as you can see there in the blue section, 30%. The next is through insect-related or Hymenoptera venom exposure. And perioperatively, it's about 4%. So not as high as food, but not as uncommon. So the epidemiology, if you look at, it's about 100 to 150 cases per million anesthetic procedures. And the death rate is about 3 to 5 cases per million anesthetic procedures. The mortality is 1.4 to about 5%. And the wide range is influenced by the differences in reporting methods, the definition of anaphylaxis itself, and regional variations in clinical practice. And the severity, it's much more in patients who are male, those who have pre-existing cardiovascular disease, and for reasons that are not clearly explained, ongoing treatment with beta blockers, this seems to exaggerate the response. At the same time, it makes it increases the risk because we may not see the rapid tachycardia that occurs with patients on these beta blockers and patients who are morbidly obese. And in the operating room, we are exposed or we expose our patients to multiple agents in succession or simultaneously. And we see it much more commonly during emergency surgery for some reason. And the patients, they have inability to communicate. So can be a reason for the higher mortality. And And we may not have reliable information about allergies in these patients because we don't have reliable skin and blood tests and they're not certainly immediately available. Now, when you look at this perioperative anaphylaxis, it's much more frequent in adults versus children. Now, females are thrice have an incidence higher in perioperative anaphylaxis, but the good thing is the fatality is less as compared to males. And in recent reports, you can look at of the 1,247 cases of severe neuromuscular blocker related anaphylaxis, 64% were non-fatal cases in females and about 63% were fatal cases in males. And these differences were significant. Now, the anaphylaxis elicitors, most common agents, as you can see, increasing incidence with antibiotics. Next is neuromuscular blocking agents and other disinfectants. And the incidence for latex, because we have recognized that as a problem, is decreasing. Uh, the non-IgE mediated reactions are usually due to dyes, antiseptics, colloids, gelatins, and iodinated contrast agents. So frequently reported are antibiotics, typically penicillins, cephalosporins, glycopeptides, neuromuscular blocking agents, mainly succinylcholine and rocuronium, and chlorhexidine that we use for skin prep, dyes, particularly patent blue, and then more recently Sugammadex, which is the newer reversal for rocuronium and vecuronium. Less frequently reported, as already indicated, is latex, alpha galactosidase, as well as gelatins. We are not using them as much. Allogenic blood components, hypnotics, opioids, radiocontrast media, and very rarely local anesthetics. Now, what is the immunobiology of anaphylaxis? There's a common theme. There's degranulation of mast cells, as you see here in this whole mast cell, mostly, and sometimes in basophils. These are IgA-mediated hypersensitivity reaction. It occurs in sensitized individuals, and these individuals have been exposed to the antigen. IgE has formed, and this IgE then, with the new exposure, results in the release of mediators. Now, this antigen-specific IgE with the reactivation binds to certain receptors in the mast cell known as FCER1 receptors. And once they are stimulated, they get cross-linking with other receptors. And this leads to the release of mediators, mainly histamine, proteases, tryptase, and other inflammatory mediators such as platelet activating factor, prostaglandins, and leukotrienes. And these are typically from mast cells and also to a smaller extent with basophils. Now we have non-IgE mediated mechanisms, which means they don't need prior exposure and they can occur in anesthesia. These are through immune complexes, through complement and through IgE and IgG antibodies. And these act on different receptors, on the opioid receptors on the mast cells, and also the human G protein coupled receptor called as the MRGPRX2 receptor. So you can see patients who will be reacting to these, but the presentation is similar as you would see with even the IgE-mediated reaction because the pathway is common. So unfortunately, the incidence of anaphylaxis is increasing at adults and children. And in children, it's increasing because of food-related allergies. And in adults, it's increasing because of drug-related allergies. You know now when you become an adult and you become elderly, that patients are going to be on more and more drugs to try to keep them healthy. So, but this is also the side effect is the increased incidence of anaphylaxis. There are certain predisposing factors that can should alert us when we see these patients who might have certain disorders. Some of these are genetic, like the mast cell disorders, hereditary alpha tryptophanemia, HAT, and those with platelet activating factor acetyl hydrolase deficiency. Now, platelet activating factor is a potent lipid mediator of anaphylaxis, and it's degraded by enzyme PAF acetyl hydrolase. In severe anaphylaxis, including that occurring perioperatively, these patients will have high levels of PAF and low levels of the PAF AH, which is the platelet activating factor acetyl hydrolase that degrades the platelet lipid activating factor. So having low levels of that and high levels of PAF means the severity of anaphylaxis will be much more. So whenever anaphylaxis occurs, one should try to look for the mediator-released pathophysiological responses and draw bloods immediately to send off for tryptase and histamine and other cofactors if you can measure those. So the storm occurs from these preformed mediators, histamine, tryptase, kininogenase, and the eosinophilic chemotactor factor of anaphylaxis, which is a tetrapeptidase. And then once these are activated, you get newly formed mediators, the leukotrienes B4s, leukotriene C4 and D4, prostaglandins D2, and also the platelet activating factor. So these factors will affect the entire body system, as you can see in this slide. Now, under anesthesia, we may not see everything, but when patients are awake or when the patients are under modern third anesthesia care, either with light sedation, medium sedation, or even with deep sedation, they might end up with symptoms that you might be able to pick up, which are not typically seen when the patients are fully anesthetized. But when they're fully anesthetized, you can see cardiovascular manifestations and you can see pulmonary manifestations. There will be in the full anaphylactic storm, hypotension and tachycardia, as demonstrated here in this slide. Because of vasodilation and increased vascular permeability, the blood pressure will bottom out, and then the patients will have wheezing or increase in airway pressure for ventilation from bronchoconstriction. There will be a reduction in the pulmonary, the oxygen saturations on the pulse oximeter, and you might even see on the skin urticaria. And if you happen to open the mouth, you can see that the tongue might be starting to swell up. When patients are not fully anesthetized, there's obviously the other symptoms. They may have rhinorrhea, might be sneezing, there'll be a manifestation of stridor, they'll complain of abdominal pain, they may vomit and have significant nausea. And these are all from the mediators, including not only the anaphylatoxins, but the platelet activating factor, as well as cystinyl leukotrienes. So like I said, under anesthesia, it's usually rapid and variable severity, but you got to always be ready to entertain that possibility. And it is responsive to the timely administration of epinephrine and rarely causes death, but has been reported as we see in this next few slides. Most recently, which is in 2022, there was a case report showing anaphylaxis to remimazolam. Remimazolam, as you all know, is a rapidly acting benzodiazepine, which is broken down rapidly by cholinesterases, and it has to be typically given as an infusion or small doses in boluses. But here they describe a patient who was given remimazolam, and as you can see here, had severe hypotension, which was initially treated with norepinephrine and then epinephrine and then an epinephrine infusion. He recovered, the patient recovered, and you can look here, the histamine levels were quite elevated, as was the serum tryptase level. So this patient went on to survive with the early recognition and treatment of the anaphylaxis. This wasn't the case with two case reports submitted. You can see here where the anaphylaxis was quite refractory and there was cardiac arrest after succinylcholine administrations. Both these patients were scheduled for appendectomy and they got rapid sequence induction with propofol and succinylcholine, and there was cardiac arrest at 1 and 4 minutes. Immediate resuscitation attempts were instituted with epinephrine using ACLS protocol, and then vasopressin and cardiopulmonary bypass in one of the patients. Both unfortunately succumbed. The serum tryptase and IgE antibodies to succinylcholine were significantly increased. So it took about, you can see here the tryptase level at 700 minutes was 200 micrograms here in patient one and over 200 micrograms in the other one. And the SUX-specific IgE were significantly elevated, and SUX inhibition was also quite high, being the normal being about less than 20%. So mortality does occur, and one has to be prepared for handling these situations and treating it in a timely fashion. So early recognition and treatment is key to avoid perioperative fatality. Now, uh, when patients are not anesthetized and they are at home, they typically have an epi pen which they can carry with them. And more recently now, which is being tried in Europe, is inhaled epinephrine to treat these reactions if for more rapidly without having to use a needle. Another one is this Prosject, a device made in France where it can be given into the skin without a needle, and it pushes in adrenaline or epinephrine directly to treat an emergent reaction. So these can be used by patients directly or even in the hospital if they have it available for emergency treatment in the crash carts. So the prevention strategies are important. Administer antibiotics pre-induction. Do this as much as possible. We try to do that in our pre-induction areas. Get the antibiotics started, run the infusion, because it helps two ways. One is if they do have allergy or an anaphylactic type reaction, they'll be awake, they'll pick it up quickly, patients will complain. The second thing is you can get an adequate blood level of the antibiotic before incision is made for prevention of surgical site infection. The other things that have been found is there are certain preservatives in medications that can be the true anaphylotoxin, anaphylaxis inducing antigen, and reducing these or taking them away from that drug will actually reduce the incidence of anaphylaxis. For instance, the folcodeine, which is one of the additives in neuromuscular blocking drugs, removal has decreased the incidence of anaphylaxis from neuromuscular blocking agents. And now there is newer emerging role of biologics, which have been shown to provide significant benefit. Patients with allergies and other immune-related diseases can be on these drugs, and the incidence of anaphylaxis in the operating room can certainly be minimized. So what are these biologics? They have been shown to provide progress in anaphylaxis care from a purely defensive approach to a proactive approach, and they have transformed the care for those with allergies. These biologics are derived from living organisms. Their components are proteins, antibodies, nucleic acids, and cells, and they offer targeted, more effective therapeutic options for managing anaphylaxis by intervening at various points in the allergic cascade and immune response. So here you can see the different places where they can act. They can target the IgE. One example is Omalizumab, also known as Xolair, a biologic that specifically binds to IgE. They may interfere with immune cells, the T cells or eosinophils, to decrease the overall immune response. They can help with desensitization, assist in the process to tolerate antigens and reduce the severe immune response. They can block immune signaling pathways, block specific cytokines, reduce inflammation and the severity of allergic reactions. And here's a breakdown of the table of the currently available biologics. You can see the one that's most commonly used, omalizumab, and then we have dupilumab, etokimab, and ligelizumab. So these are the earlier ones, and this is the next generation anti-IgE. Omalizumab is used for food allergies, airborne allergens, drug allergies, venom immunotherapy, and idiopathic anaphylaxis. There are many patients who have idiopathic anaphylaxis. We don't know the cause, and they can benefit from this drug. It increases allergen tolerance reduces adverse reactions during immunotherapy, and is effective in idiopathic anaphylaxis, improves quality of life for patients who have mastocytosis. Dupilumab is an emerging use in food allergies and Th2-mediated conditions. It reduces the Th2-mediated allergic inflammation, promising results in ongoing studies for food allergens. Same thing here. It's Itokimab is emerging use in food allergies and shows potential in increasing allergen tolerance and is under investigation for broader application. Now, ligelizumab is a next generation anti-IgE and is used for advanced IgE-mediated conditions and has a higher affinity for IgE than omalizumab and is potentially more effective in preventing anaphylaxis. So as we progress here, we're going to see more and more patients on these biologics. The incidence, hopefully, of allergic reactions in these patients will come down. And if we do get patients who have allergies that are detected in the operating room, maybe follow-up in the allergy clinic will result in them getting put on these biologics so that when they come back to the operating room again in the future, there's less likelihood of an anaphylactic reaction. So the omalizumab, like I said, is an anti-IgE and IL-4 alpha antibody blocker, and it downregulates the expressions of the high affinity IgE receptor and the FcER1 receptor on the surfaces of basal cells, mast cells, and dendritic cells. Now let's move on to this. I already talked about the omalizumab, which suppresses the IgE-dependent cascade and is applied to the care of patients with moderate to severe asthma, chronic inducible urticaria, severe food allergy, eosinophilic-related gastroenteritis, acute reactions to immunotherapy, mast cell disorders, and idiopathic anaphylaxis. The good news is that, as you can see in this New England Journal of Medicine publication recently in February, it shows that the FDA has been approved for patients with food allergies, and these children are certainly benefiting from this drug. As you can see here, when they were treated for 16 weeks, all of these children with different types of allergies, peanut, cashews, eggs, milk, walnut, hazelnut, and wheat, all of them were able to tolerate a much larger dose of the antigen as compared to placebo when they were sensitivity tested to show that they can tolerate much larger doses of the antigen as compared to without the omalizumab. Now, as I was saying, we're going to switch orders a little bit and go to Sugammadex, which has been used, is being used increasingly globally for reversing muscle relaxants, particularly rocuronium, and to a certain extent, vecuronium. But the incidence of anaphylaxis with this drug is unfortunately increasing and is currently estimated to be anywhere from 1 in 6,000 to 1 in 4,000 cases, 14,000 cases. And given that the problem is we typically give this at the end of the procedure, and so we are more likely to see it at the end rather than at the beginning. And this might occur when we've given the drug and we are transferring the patient and the patient is being moved to the PACU. It can occur in the hallway, and that can be quite hard to treat when you're not in the operating room, when you're in between the PACU and the operating room. The reason that this sensitization might be increasing is because one is prior use, which it can be, patients can get sensitized, or they might have been exposed to drugs or other items that have a similar antigenic structure, such as preservatives, drug carriers, and other commercial products. So when you do get a reaction with Sugammadex, think about drawing serum tryptase. Try to draw it within the 2 hours of the event and get levels even 24 hours later. And elevated levels are defined by an absolute value greater than 11.4 nanograms per ml. In some cases, you might even want to collect 24-hour urine sample to show that the histamine levels were increased. So like I said, it typically occurs within 5 minutes of administration because it's given at the end of the procedure prior to extubation, so patients can be extubated. The challenges are that there is perioperative polypharmacy, which we adopt in our patients, and it complicates identification of the triggering agent. So anaphylaxis at this stage can be quite catastrophic if not treated quickly, because rapid airway edema can occur and making reintubation difficult or impossible. And we may not have the equipment quickly available because we've probably left it in the operating room. So the delay in diagnosis can cause severe cardiopulmonary issues, and vigilance is crucial. So the first line treatment for these cases is epinephrine. If you have an IV, which I hope one does, it can be given quickly, and the dose is 20 microgram for moderate hypotension, 50 to 100 microgram for severe hypotension, and 1 milligram for cardiovascular collapse. In children, sometimes when you're transferring, the IV might have fallen out or might not be functional. Don't hesitate to use epinephrine intramuscularly in doses as high as 0.5 milligrams per kilo if the IV access is lost. And for reintubation, which is recommended if airway edema is happening and increasing, one should use succinylcholine. Do not use rocuronium or vecuronium. And provide full monitoring and support, and establish invasive blood pressure monitoring and IV access if necessary. So in conclusion, the incidence of anaphylaxis is increasing in all age groups. The mechanism may be immunologic or non-immunologic. The manifestations are similar. Epinephrine is the first-line drug of treatment, and newer modalities of care will help in prevention. A little write-up of this is available that I did myself along with Dr. Manar Abdal-Ghani. We talked about the role of biologics in anaphylaxis care. It's in the ASA monitor, and you can get that from the American Society of Anesthesiologists website if you look up biologics in anaphylaxis care. So the algorithm for post-anaphylaxis workup, most important thing here is that once you have a patient with anaphylaxis and you get a detailed history, you try to establish the diagnosis by doing skin tests and looking for mast cell disorders. You need to have a team approach. When the tryptase level after these episodes is normal, then they have been using what's called the REMA score, which I'll show you a few words about, to look for mast cell disease. And sometimes, the allergy is due to venom, due to food, due to drugs, or it could be idiopathic. And these patients are typically managed with avoidance of the agent itself, or by using Vemin immunotherapy, or they all carry an adrenaline auto injection in their pockets or with them. And so what will happen now in the future is that all these patients will be given biologics once we know the problem. And certainly for multi-mast cell disease, a multidisciplinary approach will have to be used. Now, the REMA score is something that has been developed by the Spanish network of mastocytosis to help in its diagnosis, and it's useful also in Hymenoptera or venom and idiopathic anaphylaxis, and avoids unnecessary biopsies in low-risk patients and guides hematology reversal. So I want to stop here and thank you for listening. I hope this has updated your knowledge in anaphylaxis and you do know a little bit about the biologics. Thank you. And I will try to be available for question and answers depending upon how things are in the operating room today. This is our hospital, the main hospital. The other one I showed you at the beginning was the children's hospital.